Hey, can you guys hear me okay?
Yep, we can hear you. Yes, we can.
Oh, good. I'm just in a airport lounge, and so I'm going to try to be a little quiet, but as best I can. But just want to make sure you can hear me okay. I can my earphones here for you guys. So okay. So good day. Let me see what I have on the schedule. See how many people are joining so far.
We've managed today, and we said today we're going to 500 patients. But we like lots of people, all the patients of cancer since day one, 30,000. If you think what Chris said, it's all about chemotherapy, and it's like he's all right.
Hey Tim, have you gotten a calendar invite, Tim Sadie?
So I think he's got to make that leap. So, you know,
Can you hear me?
Well, you have to remember that, you know, the slow down, but that was a takeaway. So I'm going to give him that feedback, and I'm going to suggest that once the slides are using from your kind of stuff, then make sure
I'm sorry, I'm losing a whole bunch of people over. Sorry about everybody for delaying things here.
What about waste management? Waste these are valuable. You know, waste management. How do you ensure that we get people to the ground? And then
Okay. Apparently not. Okay. Okay, let's get on this. Want to get things started here. And we're gifted to have David Purse on today. We'll be talking to you soon, Dave. How long do you have on that you can do this with us?
Hey, Paul, I can stay on right up until my brand new grandson starts crying.
Until when?
Until my brand new grandson starts crying. I'm babysitting.
Oh, yeah, I know that one really well. Hey, congratulations. How old now?
He's just over 5 months.
What's going to transpire in the next couple of months? I'll keep you abreast. That's pretty good.
We just put him down for his nap. He usually sleeps for about an hour, so we'll see.
Oh, good. All right, fantastic. And then next question is, let's see, how about you? Because you always have to get off a little early. Fiona, how's things in the UK?
Very much as they were. The junior doctors in the north of Ireland are on strike at the moment. That's the first time they've been on strike. The consultants look likely to accept the pay offer that they've been given. The junior doctors still haven't, and I don't see that dispute resolved anytime soon. We've just had a budget where the NHS has had some additional money, which is very welcome, but it's a drop in the ocean considering the cuts that there have been over the last 10 years or so. So not in a great place, but nothing really new to report. Thank you, Paul.
I think it's quieting down in terms of, let's say, influenza and COVID, or are we still kind of leveling out so far over there?
So there's still quite a bit of COVID around, not so much flu, but it's I think I was listening to the president of the Royal College of Emergency Medicine on the radio this morning, talking about how the last 2 winters have been just on a different scale to what we've seen before in terms of the pressures on emergency medicine. and the evidence that they have managed to provide, which suggests that there are an additional 270 excess deaths a week in the UK as a result of long waits in the emergency department.
Yeah, okay.
So the
And
4-hour wait's got a bit better. The 12-hour wait has not got better.
And unfortunately, even though you're only a few hours ahead of us, you are going to predict what I think is going to start transpiring here. As we heard last week, we started hearing more and more of this issue about our emergency departments really getting really whacked again. So, all right. And therefore delays in other kind of care as well. I'm sorry, I see a hand that says James C. Who's James C? Has their hand raised. Okay. I guess James C doesn't have his hand raised anymore. Okay, I'm not sure who it was. Let's see now. All right, let's get on. Okay, so with that, let's go ahead and start going a little bit around the room. First of all, I think we have enough people on board. Maybe I'll wait a little bit longer, but just let me still take care of that thing. Tim Sadie, can you hear me okay from Newark?
I can. How are you doing?
Okay, good. Hey, Tim, that shows you that for your calendar.
Sorry, you cut out there.
Oh, can somebody, that's connection's unstable. Of course it is. Can someone else ask him that question if you heard me?
Hey, Tim, it's Angus. I think Paul was asking if you got the calendar invite for the webinar so that you could join directly.
No, I do not.
I'll send you an email.
Thank you so much.
Okay, good. Before I forget, there is a 19374. And for those of you who are on Seagulls, I think I put in 19375. Okay, so let's see, let's go on here. So Doug raises a great question, which I'm going to wait for in a couple of minutes. I'm going to sort of come back to that, Doug, if you don't mind, because I'm going to actually spend a lot of time talking about what's going to transpire now, because we're moving the schedules up a little bit on what we've been doing in the past. Okay, let me just double check over on the other side if we don't have anybody who is supposed to bring over here. This is here we go. Okay, and there we go. All right, that's enough for now. I'll try to pay attention later on. All right, so a couple things is that I do want to say, just remember everybody that we will be changing our times, especially for Fiona and anybody else on from overseas or elsewhere, is that Europeans won't change their clocks for a couple more weeks. We'll be changing ours on Monday. So instead of a 5-hour difference between UK and East Coast, it'll be down to 4 hours, I think, because of our spring forward thing that's happening on Sunday. Just a reminder for those of you from over on the Euro side. Then you'll catch up with us in a couple of weeks and all that. So it is interesting that that there is a difference there, and I'm not sure what the explanation is, except for latitudes and longitudes and all that kind of thing. All right, and so that's why I said I put here. It's the time we always tell people, remember to change your CO2 detectors. And my biggest issue is always updating my car clock. So keep that in mind as the day goes on, so you don't lose track of things. Okay, so now planning for the June swoons. Let me make sure I've got. Anybody else I have to move over from the other side here. Okay, good. All right, so here's what we're going to be doing is, first of all, there'll be 3 emails, probably 3 or 4 that you'll start getting. But just for this, so first of all, to put the dates down, most people, unless you're going to stay for a few days or come early with your family or afterwards, most of us will be arriving on June 10th. So if you have to get permission, that's why this is so important to know right now. We're going to be sending out some information in just a little while. But June 10th will be kind of an arrival date. And then the Eagle Creek will be Tuesday. June 11th and June 12th, which I hope you could bring your fellows to. And I'm thinking about dedicating things like, as I said, to make it as much as a fellows day as we can on Tuesday, along with the other things that we do. So in event, that would be those days. And then the main meeting will be on the 13th and 14th, June 30th, which is a Thursday, Friday. So I hope that gets you plugged in for that, if that helps you, okay? So no information has gone out yet, Doug, but we are basically getting ready to send out. What has been sent out this morning, by the way, just so you know, is the following, and I'll walk you through it. So let's go to my share screen here. And if I go to my emails, where they are somewhere, sure. See if I can find my email. Okay. That's not it. Okay. Well, give me just a second. I'll find my email. Because this is what you'll be getting as an email here pretty soon. Hello. Okay, here we go. Survey. This is probably it right here. What you'll get is something that looks like this. You click on things. There'll be a certain people who I'm asking to get topics for. That'll be the first thing is topics. And what it would look like is you'll get something else, and that's not what I'm looking for here. So I should have been better prepared. Sorry about that. I was prepared, but something happened. Conference topics. Let's see if that's it. Could be there as far as I know. Nope, that's not it either. All right, where is my, I think I just have to open my email in general. But while I got this up, I might as well just show you is that we're going to be aiming to do similar to what we did in the past. I'm not doing very well here, so I'm probably getting a bunch of distractions also around me. Let me see if I could just come up and just give you a brand new, open up my Gmail. Here, Gmail. All right, and let me go to Mark Worth. Nicely put this together for who works closely, of course, with email list, email equals meeting. Nope, that's not it either. Let's go to Mark Worth, Colorado Springs, but she worked with Stein and they've done a great job. So here's the survey. So what you'll get is something that looks like this, I think. Let me, nope, wrong one. Let me go ahead. Survey. Getting ready to send the survey out. Take a final look before I distribute. Okay, so let's take a look. So what you'll probably see is something that looks a little bit like this. You'll get Eagles main conference presentation. So what the first thing you're going to get from me is something that's going to ask you for your topic. So as we've done in the past, I'd like to get 2 or 3 or 4 of these, probably 4 over, more than 4 is going to be overdose. So just put these in order of priority so I know what's a priority for you. And then what I'd like to do to make it easier and probably help me understand what you're doing is you'll put in, a name like this right here. So in my case, I'll put down Rocky Shores. Okay. And then your affiliation, I'll say Brown Sequard University. Okay. University. And One Willis Circle. You don't have to put the address, and I think if you just say Denver or whatever it might be, in your case, One Willis Circle. All right, but I think you just need your affiliation there, and that all I need is Detroit or, let's say LA County or whatever it may be. Anyways, the way it's going to come out and read is that this is going to be specifically the topics for the main conference on Thursday and Friday. I don't know which day I'll put you on because remember, I have to create this puzzle of all the things that get these mini symposia put together. So I'm just saying really nothing new, just list up to 4 topics that you'd prefer prevents, and 1 or 2, 3 topics are acceptable. And where it would be nice to list them in your preference of order so I can try to accommodate that. And then this list will be used to create the various pieces of a patchwork that I make the mini symposia. So 1 or more of your topics may or may not be chosen to help fulfill those larger picture purposes. And they could appear either on Thursday or Friday. So keep that in mind as you make your reservations, so that if you can leave after 5, 6 o'clock at night on Friday night, that would be great. Or if you need it, on Saturday morning. However, your indicated favorites will be prioritized as much as I can, or maybe even as I've done in the past, put you on Eagle Creek days if I think it's a cool topic, but just didn't fit in with the rest of it. So, and then the format of your response, what I was going to ask you is that you give me a title and then pose 2 to 4 questions. So the purpose of doing this is to say, what are the 2 or 3 things you really want those people to walk away with? What are the, what's the take homes that you really want for your presentation? So if it's a 5-minute presentation or a 10-minute presentation, when they walk away, I want them to know this is the thing you want to do. So I gave some examples here, and I'd like to do it in questions because, as most of you know, I'd like to see this as your second, or it doesn't have to be the second slide, but I'd like to have it really up front that here are the 3 or 4 questions you're going to address, or the 2 or 3 questions you're going to address during your talk. So if Fiona says to me that we had a bunch of strikes last year, right? Then I go, okay, how's that important to me? What's the message? They go, and the question is, do you have a plan if 80% of your people don't show up to work one day, right? Or what would you do if your dispatch center is blown up? Do you have a redundancy plan for your dispatch office, or so on? So I gave you a couple examples here. Is that the topic seizure systematically terminating benzo-resistant convulsions? What would be the rationale for using ketamine in patients with status epilepticus that's not responsive to ample dose of midazolam? Because that's what I'm going to teach you what that rationale is about the downregulation of GABA A and upregulation of NMDA receptors. How does ketamine terminate convulsions in this scenario? Or how often does it? So that will be the people want to know, yeah, how often does that work? So when I give the answer, it's going to be fun to get that. You want to know that. And then what is the frequency of complications? That's a good point. What are the complications? So when people have presented things, I know those are the main things we want to know. If we do this, and then what are the downsides of it? That kind of thing. So those are 2 or 3 questions. So I gave you some examples to play off of. Okay. Then when you get into this, you'll see titles. So here's where you would take one of those things we just saw. I don't know if I can go back. I think I can. So let's just say what I'm going to end up doing is taking the topic here, and I'm going to copy and paste it off of a Word document that I had, and I'm going to plug it in right here. Let's see if I can get this to hello. But that would be great. You could do it if you could, if you could format a little bit so I can read it easier, that would be great. When I get this from Mark, he's going to put together a spreadsheet for me. And then here's the second one and all that. And then for those who really want a 4th one, you can go on to this next part and they'll give you a 4th option here. So, okay. All right. Now, then the next thing you do is you'll put in your email, your phone number, so I can reach you if I had some questions about whatever I was reading or I didn't understand. And then after that, you could add any comment or call me about this or whatever. So, all right. And that's it. Then you submit it and then there you go. So is there any questions about that? Hey, were you able to hear me okay, by the way? Fiona, were you able to hear me? Okay, good. All right. So let me get out of there. Then the next thing is you'll be getting something that looks like this. Let me see if I can find an example of it. But we're going to put together kind of a survey where we're going to ask you about funding. Are you going to be able to fund yourself? Do you have a source for it? If you can, that'd be great because it would contribute to the greater cause. So let me see if I can find my thing here. And then go to, let's see if I can get rid of this thing here. Okay, and pretty soon you'll be getting something that looks something like this, if I can find it. Recent Eagles brochure topic survey, or let's see. Okay, Eagles scheduling and reimbursement. Now, then you'll probably get something that looks like this later on. I think will be sent out. And it says, make your scheduling plans now to make sure you will have your expenses cover and or optimize your cost because the hotel block and other deadlines are approaching. So what we're suggesting is that here's the information will be coming to you to reply to what you were asking me, Doug, is that unless you plan to come early and stay late, we're asking you to plan on arriving on the June 10th, Eagle Creek, June 11th and 12th, Maine Eagles 13 and 14. Plan on departing late Friday after 5 p.m. to ensure your talk will be included or as needed on the 18th. We will be staying and playing at the Seminole again this year. Okay. which is again, very close to the Fort Lauderdale airport, about 8 miles, to 15 to 10 minutes away. For those of you who, maybe are traveling from long distance or overseas, going into Miami might be good for you. That's about 45 minutes to an hour away, but nonetheless, relatively close, etc. And then we'll be sending a formal survey about your arrival and departure dates. That's why I want you to do your scheduling and do all that stuff right now and look at your airplane tickets. We'll set up the hotel reservations for you, whether or not you will be paying for it on your own, to make sure you get the best rates. So we're going to give you information about that. So that's why we want to move this along. So over the last few years, we agreed that if we need to, we would cover our costs if we had to. But the good news is that because of a lot of you have used your own institutions or other funding, we've actually done really well and got everybody fully reimbursed. And so in view of that success, this year, we hope to expand the group to fund more international Eagles, and that might ramp up our costs, but I think we're going to still be okay. But the point is that if you have available use it or lose it funding from your institution or other source, it would be appreciated to have you cover your own costs and increase our overall cost so we can make sure, because we're allotted only a certain amount of money to cover these things. So we'll be asking whether you want to be a category 4, where you just basically donate to the support of a 501(c)(3), make sure your accountant says that's okay for you to just deduct that. Category 3 is that I've got a funding source from the university or whatever, and so I don't need to be funded. And some people say, hey, I could take care of my airplane flight, but not the hotel or whatever. So that's the other thing you can tell us about. And then eventually category 1, which is the most of you that are usually here with us, are going to be all paid for if you don't have those other sources. We'll take care of you. And as needed, these could be modified later as needed if something goes wrong with your funding source and all that. So immediate action is identify your reimbursement category. We're going to get you a link and all that done at that time. Get your schedules and airfare squared away so you keep your costs low, and then also the hotel nights that we need to lock in. That's it. For those of you who might be paying for yourself, we're trying to get all the air domestic flights under 500, and that may be tough. I've been seeing that, so I put the little star in, particularly for people coming from overseas, because it's very expensive nowadays. Hotel, just for planning purposes, is about 179, plus there's a resort fee, and then you add the taxes in. It's about $235 a night, or about $941 for 4 nights, or $1176 for 5 nights. So you'll be getting all this information. I'm just trying to give you a heads up right now. Okay. And if I'm moving too fast, let me know. Between the airports and the hotel, it's about $20 each way, just so you know, whether you use Uber or Lyft. And then, of course, the registration, meals, and Wi-Fi will be provided for the core group, and we'll be letting you know who you are when that time comes. So please call me for any questions, etc. And again, for individual concerns, issues, overseas, Eagles, etc., please contact me. We'll talk about the plans. We'll see, but just try to get the cheapest scan. So I want you to plan now is what it comes down to. All right. Was that all understandable as well? David, Fiona, did I go too fast, or is that good? Okay. All right. Any questions?
Are you gonna have, Paul, are you gonna have, for those people that don't do smoking, are you gonna do the Meridian again?
I think it will be available. So the person who you contact, let them know that, and that will be probably Johanna Sinque. I think many of you worked with her before. She handles all the hotel stuff. So just let Johanna know that you'd rather go over to the Meridian, wherever you want to be, etc. Okay. So, okay. Anybody else have any questions? Oh, hang on for a second. I gotta take this. Hey, Eric, hi. I'm actually was trying to get you on a call. Can you, if I send you an email, can you get on a webinar that I'm on right now? Okay, got it. I'm gonna send you a thing, right? Thanks. That was Eric.
Oh, should I do that for you?
Yeah. Can you get a hold of
You
Eric
want me-
for me
you want me
and
to
put him
ping him?
on and help him and get him on? Okay, so that'd be good.
Sure.
And then track him to make sure we could put him on, because I thought it'd be great to have him discuss the outcome from last week's sentencing thing from the Colorado case. So, all right, I think I've covered most of everything. Anybody have any questions? That at least these are, and then you'll more information as time goes on. Peter, was that all understandable? Is that okay?
Yeah, it's great. Perfect.
Okay.
Easy.
Good. All right. I just want to make sure we're done. And Stein has been fantastic about helping me out there with Mark Ward. So we'll let you know about how you know, how it all goes. What'd you say here, Stein? You said if anybody's not getting the emails, please let me know.
Yeah.
Is that right, Stein?
Yeah, there's just some people who, you know, the emails are sent back, or we may not have an updated email. If there's anything that happens and you're not getting the email, just let me know and we
Yeah.
can update things.
Yeah, and let me know because I didn't even know your email was even on our invite list. That's really funny. Yeah, and actually Ken Shepke was missing too. I mean, it just was bizarre. I don't know. So it maybe just sometimes in copying over some of these things, but I think we captured almost everyone. We did a pretty good job of that. I got to thank you guys so much. Okay, Doug, that squares you away, right, for your question and everybody else, I hope. Okay. So
Absolutely.
All right.
Thanks, Paul.
okay, good. And by the way, we're going back. Demand. We're going back to Padrino's restaurant on that Tuesday night. That's the place where they gave you unlimited sangria and food and all that. That was a great place. So just want you to know. And then head to Tropical Acres on Thursday. And Wednesday night's usually the night where people like to be on their own or go work with people to put together their talks. If I give you like triplet, you know, a duet or triplet type of presentation. So okay. So let's see what else I have on my list. Let me know when Doug is on, Peter, if you don't mind. Thank you so much for helping me with that one.
I mean, Eric, yeah, Eric is on.
Oh, yes. Okay, good.
Hey,
Hey,
Eric.
so then let's see, register your opinion. Don Jenkins, are you, let me see where Don is. Are you there, Don? Maybe he may be in the attendee list here. Let me just see.
No, he's not. I pulled over people.
Okay, he was going to come on and talk a little bit about that registry thing. Again, I just wanted to make sure he did that, but we could just discuss. That's not really urgent, and it's really old stuff anyway, so it's good. All right, let's just do that. Let's go to Eric. Eric, you come on and Peter, can you do a quick introduction of Eric? That'd be great,
Sure.
Okay.
especially since
Sure,
he's up
so,
in New England, and I don't know anything about New England, right? So.
Yeah.
Did you know I lived in
no,
Ogunquit?
Eric-
Eric, did you know I lived in Ogunquit for years? And
Did you really?
I used to cook 600 lobsters a night during the summer at one of the lobster pounds there. You know, and I got really
Anytime
fast.
you want to,
Go ahead.
anytime you want to come up and have a lobster bake on the beach, just let me know.
Sounds good. I used to do on the average about someone calculated I did about 80 lazy man lobsters a night. So I got really facile about taking the meat out, and you know, that was pretty good. So anyways, yeah, so but I don't know anything about New England at all. So, but hey, go ahead, do the introduction, Peter.
Yeah, so Eric is an underachiever.
Yeah,
he has
right.
he has a BS in computer science from MIT. He has a law degree from Boston College Law School. He's an EMS educator, an RSI paramedic at Exeter Hospital in New Hampshire. He serves on some state committees. And Eric and I met when he was really talking about, you know, a lot of these issues that are happening with implicit bias, which he gives a great talk on. And then he gave several talks at NEMSP this past year related to the Elijah McClain case. And based on his webinars, we've already changed what we do at our agencies. We've changed our SOGs, our protocols. So Eric is just a fascinating person, really smart guy, and someone that we've R&D'd quite a bit from. So Eric,
Yeah.
thanks for joining
And
us.
Eric, I just want to let you know, when you said he had his BS, I said, yeah, emphasis on the BS stuff. No, because he's really, no, Eric is fantastic. And I want you to know, I want to give you feedback because the guy from the Associated Press, you know, talked to that's covering this, right? You know, talk to me, talk to Peter. I could go on and on, all these people, right? But the person he thought was the best was you. So I just want you to know that. So, okay. So,
Well,
any
I
bets?
appreciate all the kind words. Really, what my resume reflects is I can't decide what I want to be when I grow up.
Yeah.
So I'm still figuring that out, but we're having fun along the way.
And Eric, before I forget, and before you launch into this, because we may have to move along, one of the things I do want to talk about is you were talking about the issue about asphyxia, and you were saying, you know, I'm actually a pulmonary by training, I'm a pulmonary physiologist and boarded there, and I can tell you, you're right on track, and I can explain the reasons why. So we can have that offline because that might be helpful for your talks in the future. Okay, so thanks.
Yeah, I would love a deeper dive into the pathophysiology piece, and I think there's a spirited debate on the acidosis versus hypoxia equation in these patients.
Yes, yeah.
And I would love to see more research and publication around that, because I think that's a piece that needs further illumination. But so, yeah, I welcome that conversation.
And then the second part of that is I just finished, I just have a paper going under peer review right now. And it talks about the use of ketamine in seizures, which is kind of an asphyxia can happen there because they're not taking deep enough breaths, not, you know, they're convulsing away, especially with status epilepticus. And it turns out ketamine ended up being protective there because they dramatically improved their oxygenation and carbon dioxide status. So, but I'm just saying, let's you and I do that later. But I just for now, I thought it'd be kind of a cool thing. So let's talk about, just give us everybody I think knows about the Elijah McClain case pretty much. I think that the main thing is to say, what is the reaction and what was just before they, before you heard about the sentencing last Friday, and I actually watched it live myself. Peter and I did, I think, and it was kind of interesting in itself to see the courtroom interaction there. But I want to say a little bit just before and a little bit just after. What's your reactions to all this, and what's your advice to the rest of us?
So you're talking specifically about the sentences, the convictions of the two paramedics in the Elijah McClain case and their sentences. I think there are a number of really important lessons there. I also watched a fair amount of the trial and the sentencing. I think you guys know that when we talk about these cases, I always take great pains to say, look, I'm not the right person to judge the paramedics involved, because I don't know what their protocols were. I don't know what their medical direction was. I don't know what training they got. And I have said before that while this was a tragedy for Elijah McClain, it's also clearly a tragedy for these paramedics and for their families, right? I mean, what was shocking about this criminal case, right? We've seen EMS providers before and paramedics subject to criminal charges, but usually, I mean, they're always terrible, but usually it's, diversion of narcotics, sexual assault, theft from patients. This was fundamentally different. These paramedics, nobody alleges that these paramedics wanted to do Elijah McClain any harm. And so one of the questions that I keep getting is, how the hell this, we understand that sometimes we end up getting sued civilly. We might have a state agency take action against us. How did this end up as criminal charges when there's no allegation they were intending to do any harm to Elijah McClain? And I think one of the take-home points for all of us, and it was graphically illustrated here, is that gross negligence in and of itself can end up with criminal charges, with a conviction, and going to jail for EMS providers. And I think that's a little shocking for all of us. I will say, and feel free to jump in, Paul or Peter, if there's a particular point you want to focus on. But another thing for me is the use of protocols here. We saw the prosecutor in this case pull out the protocol that these guys used and sort of walk down it, almost as though it was sort of a mandatory set of prescriptions that needed to be followed in rote fashion.
Because there's been a lot of
Hey, Mark Gautreaux, you're live, just so you know. Thanks.
When I write protocols for the state of New Hampshire, I've done that for nearly 20 years. And I've always said to providers that protocols are not strict rules. They're guidelines that are intended to be interpreted in the context of your professional judgment on scene. Boy, I have to say, we saw the prosecutor take the protocol and sort of walk down it, and each step in the process that these guys allegedly missed before giving the ketamine was, sort of almost a strike against them. With the end result is the prosecutor argued that the correct dose of ketamine here was 0 because they hadn't met the prerequisites for giving the ketamine. And again, I think that's, I will say here in New Hampshire, I'm known as Mr. Consider, because as we go through each protocol, I'm often the guy adding consider at the beginning. And my thought process there is, if I have a protocol that says give epi 1 milligram every 3 to 5 minutes and you fail to do that, well, you arguably have violated that protocol. On the other hand, if the protocol says consider giving epi every 3 to 5 minutes, then I think I've left you room for the exercise of your professional judgment. And I think that's one of the takeaways here, is that we all need to look back at our protocols and make sure that in the language we've used, we've left room for the exercise of paramedics' professional judgment. I'm going to pause there for a second. See, Peter, if there was anything you want to add, or Paul, you want to add on either of those.
Yeah, so I just have one real quick, Paul, and I wonder, you know, you're an attorney, and it's great to have an attorney who's writing protocols. How many people in this group are actually using an attorney, you know, like a PWW, et cetera, to actually review their protocols after what we saw with how they picked apart every single letter of this protocol? How many people are actually using them? And is that an idea that we should all look into? Question.
So, it's a great question. I don't know the answer, although it's funny because I'm both a paramedic and a attorney. I'm run into a lot of fellow paramedics who are also attorneys. So there are more of us out there than I thought. And even if you're not using, I don't know that we're at the point where we need to like have our protocols reviewed by an attorney before we issue them, but it might not be a bad idea to have your protocol committee have a conversation with an attorney to understand and look at some examples to ask the question of how can we write this protocol in a way that preserves maximum flexibility for our EMS providers and reduces their potential exposure.
That was my thing, to make sure it's vague as possible. You stick to the guideline kind of concept, and you rely on your training. I mean, that's the real thing. Do they really know what they're doing, not just on a piece of paper? Because anybody can interpret a piece of paper in any way they want, especially a plaintiff's attorney, right?
Yeah, and I will say, Paul, one of the things, and you guys down in Florida operate a little differently than we do up in here in New Hampshire. Even in the past, there's been some push-pull between those of us who are actually out in the field, or EMS physicians supervising providers, and sometimes the Bureau of EMS, who can look at these protocols as rules that need to be strictly followed. So I think this is actually an issue even before these criminal convictions came along, that we should review our protocols to ensure that we're retaining room for that exercise of professional judgment. And these criminal charges have really put a fine point on that from my perspective.
So you're bringing up a good point, because we in Florida and those in Texas where I have worked, okay, well, and years ago it was in the state of Washington, but it's a different animal now. But we are independently allowed to do this, whereas some other states that the tablets are brought down from the mountain for you to follow in many cases, and that makes for a different story and it really needs to be reviewed in those cases now.
I think for me, so I do think it's time to at least have a conversation with an attorney. I wouldn't recommend necessarily, because I don't think they know the medicine well enough in most cases to be useful to review an entire protocol set, so much as have the conversation about, when you're writing them, what are some of the ways that you can write them that retains that room for exercise of professional judgment. That would be my advice. Paul, I can't hear you.
Yeah, it's interesting because that's sort of the way the American College of Surgeons has gone more recently with their triage protocols as well. It's the same kind of thing where they're emphasizing a lot more training and more professional judgment. It does put more on us to make sure that we as medical directors know our people know what they're doing. And that may be an issue here for all I know as well. So anybody else want to pipe in on that? Anybody else want to pipe in? One of the other challenges too is that some of us have actually not gone with, let's say, things that are out there that are standard protocol out there, which is a whole nother issue. Like, David Miramontes, you want to comment on that?
Yeah.
So in Texas, we have delegated practice, which means that you're really functioning under the physician's license, me. And so we have what we call COGS, which they are clinical operating guidelines, right? And a lot of times, a lot of our folks actually have to use two at once. I'll give an example. You have somebody who has CHF and their sugar's low. So you may have multiple protocols you were doing at the same time. And sometimes our young paramedics, especially, go, well, I picked that one and did this. I'm like, no, you need to pick that one, and that one, do all of that. So that critical thinking piece is all part of that process. That I think that we're in the education, especially in the registry, we're trying to teach that. But just because it says you can doesn't mean you should. Another good example of that is if you're a paramedic in the back and someone goes sour on you and you need RSI, you should not RSI. You should do the basics, which is high flow tube, make sure you have an airway, ventilate the patient yourself, and then they can do the RSI at the ER where you have more time, space, people, and you can do all the pre-checklist before you do RSI. So just because you can doesn't mean you should. And especially with in our system, especially for ketamine, high risk stuff, the union came to me, and which is rare, right? So the union came to me and said, Doc, we want to make this ketamine stuff and sedation a physician only order. And I about fell out of my chair, right? Because usually the paramedics are asking the opposite. They want it, protocolized. And I said, so tell me more about this. And this was at the time when all this was starting. And they said, we want our guys to have some backup when they're making a decision for sedation. And I said, oh. And then I thought about it a little bit. So when they're calling me for an order for sedation, I can't see the person. So I don't know if they're black, white, pink, purple, or yellow, right? I have no idea. All I know is the patient a danger to self, danger to others, possibly a psych exacerbation or a methamphetamine overdose. And in order to manage the patient, we have to give sedation. So it takes that bias out, so to speak. And I'm not talking to any cops, right? So I'm just talking to the clinicians at the scene. And then I can give them backup. So now it's physician giving an order for sedation, not the paramedic doing independent judgment. And I think that's important.
And I'm going to go next over to the two Marks in LA and San Jose, because in California, I think the tablets are brought down from Mount Sinai in many of those situations. I want to see how this affects you. But before I do that, Peter, can you comment on what you guys decided to do and some of the results you had about the ketamine call the doctor thing?
Oh, okay. Sorry, I was talking to somebody here for a moment. Yeah, so we actually looked at a lot of our calls and we realized that ketamine was kind of leaning toward just being used more freely. So Ken put into place that for all ketamine usage for behavioral emergencies, that there had to be a call into the physician. We held that on for about a year, and I would say 9 out of 10 times it was a no need for ketamine. And so we found that very interesting. We've since changed our protocols, added droperidol, and now for the behavioral, we're reserving ketamine for the really severely agitated, the excited delirium, quote unquote, type of patient.
Yeah.
So, Paul, can I jump in for 1 second?
Absolutely.
Yeah, so I would say, first off, I think having them call medical control, I agree, it does take some of the bias out of it and give them that independent check. And yet we have not done that, and it's not something I routinely recommend be added to this protocol. I have seen other agencies require either a supervisor or a second paramedic to come in as sort of an independent set of eyes. And I think that's a good solution for agencies that have the resources to do that. Someone whose sole focus is kind of to act as an independent set of eyes, an unbiased set of eyes. I also think I did want to go back to what David said, because he was talking about the RSI. I actually think, and this could be my plug for the right way to do it, is that you need to stop thinking about ketamine administration of these folks as a med administration and think of it as a procedure like RSI that needs all of the same sorts of safeguards that you build into your RSI protocols need to be built into your chemical sedation protocols. And I think with those safeguards built in and the appropriate training, and I honestly do think we all need to go back and retrain with our paramedics to make sure they understand what we're asking of them. I see a dramatic change in how these calls get approached, and I think it significantly enhances safety. You're muted, Paul.
Yeah, I got it. After I talk to the folks in California, I'm gonna pop you over to Denver and see what the repercussions have been there. But also I want to talk, I don't know if Rob Lowe is on, and talk about some of our, when you bring up the issue about a procedural approach, that's exactly what they've done. It's not just a binary yes or no. It's kind of more of a depends on kind of situation where they've handled it in other places. So let's go to Mark Cohen first. Mark, so for example, let's go back to the issue about protocol versus guidelines, and how much flexibility do you have there? How are they written up, or do you feel that you're got your hands tied by them?
We have sort of some medical care guidelines and quite a few protocols. The county here in Los Angeles has a medical advisory committee that most of the medical directors of the provider agencies sit on. So we do help to develop the policies and try to keep it fairly, I suppose, for the paramedics to follow. They always have the option to call into the base hospitals for direction. But most of those base hospitals at this point, the MICNs are just following the same protocols that are in front of them and kind of saying yes to the requests from the paramedics, just going down the protocol. There's not a ton of thinking that's built into that, which is obviously has some benefits as well. But we have I would say almost a much more limited scope of practice that we have for our providers, sort of a smaller pharmacy that's available to them. We don't do RSI. We've got midazolam, but not ketamine. So it's kind of sort of more of a limited thing, which I think keeps them out of trouble for the most part. With the option to call on a recorded line to the MICN at the base hospital, it gives them a little bit of cover. But at least so far, haven't run into too many legal problems with this model.
Yeah. How about you, Mark, up in San Jose? Anything else you'd add?
No, I mean, California does have a very kind of a more conservative bent than many other areas of the country. We don't have RSI anywhere in the state of California at this point. And it's one of those where, I agree with my esteemed San Antonio colleague that it is not often required, but similar to many of the very, very low occurrence but high acuity procedures we do in the emergency department, when it's needed, it's needed. And so, arriving at a balance of how many paramedics do you train to do the procedure and under what circumstances can be difficult. I can tell you that trying to maintain proficiency in every paramedic on every engine and truck company in a city the size of San Jose, probably not doable. And so we're working on trying to figure out how many paramedics should we try to train in this, and to what level of proficiency do they need to be trained? I think they need to be trained to the same level of proficiency that I am. And then how do we affect that? So
yeah. That's a great point. And Jacob, I don't know if you can do it within a minute or so, but tell us a little bit about how you have a staggered approach to the patient who has the severe agitation.
Yeah, I mean, things in a complicated environment, things are simplified a little bit by the fact that we don't have ketamine. So we pivoted to a kind of a dual approach, emphasizing midazolam and droperidol if it's needed, and sort of starting with midazolam for the more sympathomimetic patients. We just adjusted our dose a little bit so it was a single time appropriate dose of 5 milligrams, and then any additional midazolam is a call-in. And yet, if you need additional sedation, you can switch to droperidol, and really trying to emphasize droperidol for other kind of non-sympathomimetic etiologies.
Yeah.
It feels like we've got a little bit of an uphill battle with our medics who tend to just jump to midazolam first, but the ones who are kind of utilizing either droperidol first or combining if needed are having some good results.
Now, let me ask you this. A lot of the theme coming down from Eric before that I'm trying to spin off of has to do a little bit with, how you write the guidelines or the protocols. How much in Colorado are you, are you obliged to follow whatever's handed down to you?
Yeah, I mean, we have a fair amount of consider as well. I would say for this throughout our protocols, I think for this sedation one, we just given our environment over the last couple of years, we laid things out a little bit more prescriptively of just do this, then call if you need more. And it was definitely more prescriptive, whereas some of our other ones are littered with consider, which is elsewhere.
Hey, Paul.
Go ahead, Eric. Go ahead. Pipe in.
Yeah, I'm going to have to go in a moment, but I did want to let folks know that I do expect that we're going to see some more national press on this topic in the very near future coming out of the AP. And it was interesting, while many of the deaths we've seen have involved ketamine, and I think there are reasons for that. And I think Versed might have some properties that make it less likely to cause that result. They are, I know when they come out with their materials, they're going to be focusing on at least 2 deaths that occurred with midazolam. So I, as much as the conversation often centers around ketamine, and I've heard before this concept that other sedatives are safer, I still think for me, it comes back to how do we ensure that the whole procedure, the whole approach is the right one, regardless of the sedative that you use, even if some of them may have a slightly better safety profile.
Yeah, and then the other thing is that I think one of the things that you said is that it being the drugs as it's how they're being held down, in those cases, and it's more of an asphyxial problem than it is the drugs per se, correct?
Agreed.
Yeah. Okay, we can get back to that later. Maybe you can come back and do a little bit more of a physiological talk as well. And Jake is from Denver, just so you know, Eric. Okay. Jake?
Sure.
Yeah, I think that's a really, really good point. And actually one of the things that we have really emphasized is that what we're really calling post-sedation resuscitation and monitoring, and emphasizing, with that is essentially the position of the patient and making sure that we're getting out of a prone position as early as possible, but then all of the monitoring. And we actually just instituted a provider specific sort of metrics that we give back to them on how they are adhering to the post-sedation monitoring. And it doesn't have discipline associated with it. It's more of an educational piece, especially around documentation of after you've done sedation, what are you doing to monitor after that? And we've had some reasonable feedback around it after some initial resistance.
Yeah. Okay. Good. Let's just for fun go over to as usual, because it's always fun talking to you, the smartest guy in the room kind of thing. John Jew, you guys have elected to actually use Geodon. Why is Geodon? What's the advantages to it in your mind compared to droperidol or midazolam or ketamine?
Hey, Paul, there's some history behind this. Can you hear me okay?
Yes, we can, sir.
Yeah, so we implemented Geodon when droperidol was black boxed. And so that's the history behind it. There's no clear advantage of Geodon versus besides the length of activity and the duration of activity. I'm a personal fan of droperidol, but right now our system is so ingrained with use of Geodon, and it has less side effects than I would say than droperidol, but droperidol is a little bit quicker in action. For Mark's concern here, our community, the entire Pacific Northwest, performs drug facilitated intubations. And regarding what was commented on by Eric, we have over about 700, we have about 280, 290, I would say pharmacologic sedations a year using the combination of Versed and Geodon, and we have not had a complication over, I would say 10 years since we've been using it. We do use high dose Versed, like 10 milligrams. And when they have given multiple doses, high doses, they've had to intubate the patient, but they handle like a RSI, and they're very well trained in our RSI. We do about 1,000 intubations a year. We do all intubations in cardiac arrest, not necessarily for better outcomes, but that's for maintaining our basically our procedure skills. Does that make sense? So that the quick question is, we've had very good luck with combination of Versed and Geodon in that setting.
I asked that as just an FYI to tell about other things we're using, but again, I think the biggest point, it may not be so much the pharmacology here as other things that are going on at the time, including the patient themselves having the underlying problem, etc. One of the things go ahead.
Sorry. The other issue on, and this is personal anecdotal observation, the Geodon is much more slower than the ketamine. Does that make sense as well? And so that gives people a much more time to adapt and get the monitor on and watch. So I think the rapidity of absorption of the pharmacokinetics is really key. And basically our medics are basically tell our law enforcement colleagues, back off, we need to get to the patient. Does that make sense? So there's a operational dynamics of the pharmacology of this drug.
Can I go ahead, I just want to strongly agree with what was just said. I personally think ketamine's a great drug. I think we should keep it as part of the formulary. I think it's very effective for this purpose. But I think if you are not aware of the pharmacology of ketamine and how quickly it can work, I actually strongly agree that the reason we haven't seen as much of an issue with other sedatives is their slower onset gives you more time to get to that post-sedation monitoring and less likely to get in trouble. I think if you understand this about ketamine, it can be used very safely. But I think if you fail to appreciate the rapidity with which ketamine causes dissociation, I do actually agree that is where we've seen some of the problems occur.
One of the interesting things I was going to say is that I think a lot of you saw the email and some responded. They actually they've been using this and tracking it closely, the use of ketamine for these situations in this country of New Zealand, have had zero problems out there, which has been kind of an interesting thing. You would have seen that, and I can probably get you some of that information as well. But the thing I did want to pivot to here real quickly is what was brought up by John, the words law enforcement, because we haven't heard that yet in a sense, in some respects, because that's another important aspect of this and the protocols and all that is, and what we've emphasized to everyone in the past is that has to be done even at a fire chief, police department level, to decide what the protocol is so that the paramedics are not put on the spot that they didn't help the police with this or vice versa, etc. And I think that's an important part of the protocol. Dustin Calhoun, you work closely with the police department, don't you, in Cincinnati? Are you guys doing anything along those lines?
I do work quite a bit with the police department here. We have not had this issue. I think that despite the fact that Cincinnati is frequently way behind the times, we were a little ahead with this as far as recognizing an issue, and have had a lot of discussion with law enforcement. I spent a lot of time on scenes with guys, and I have never seen or heard of the kinds of interactions that would lead anyone to think that the medical care being provided was actually executing law enforcement wishes. So that we were careful with that early on this. That said, we don't have ketamine in the field for sedation in Cincinnati quite yet, but we're still working toward that. This has not changed that decision.
And somebody who interacts and has probably dozens and dozens of these events happening every day is in New York City. Glenn, any comments do you want to add to this?
Yeah, we were waiting and watching this with bated breath as well. Now, our protocols in New York City are put together, obviously, by the state and then the region. So New York City REMAC, Regional Emergency Medical Advisory Council, puts it together. We do have ketamine in the protocols for the hyperactive delirium and for procedural sedation to intubate and to PACE or to cardiovert. We've elected, even before all this came out, that first of all, we didn't have ketamine on board our regular line paramedic units until
Philadelphia passenger Holdsworth, please recheck the front desk. Philadelphia passenger
Sorry about that. Hang on, I'll get rid of it.
And previous to that, it was just our rescue paramedics in a confined space where we'd use ketamine. But a year and a half ago, we allowed our paramedics to carry it. But again, we're not allowing it for our hyperactive delirium cases. It's only for procedural sedation. And I just looked at the number recently. We had by paramedics, FDNY paramedics, in 2023, 118 cases of ketamine being used, all for procedural sedation. At the voluntary, because a third of our ambulances in the New York City 911 system come from hospitals. We call them voluntary. They have their own medical directors and they can decide to follow that. They used ketamine about 35 times, of which 5 were for the hyperactive delirium. And from the reports that we've gotten from them, no adverse outcomes.
The main thing I do want to bring up now is that something that the AP reporters that I had mentioned before were really focusing on is that what is the vibe? Do we have a feeling that people are going to less apt? We already have staffing issues as is, especially after COVID. But is this going to also add to the fact that people may not want to go into be a paramedic because they may get into trouble, with and go to jail, that kind of for practicing medicine in the streets. Interesting thing. You want to comment on that, Eric, real quickly? Because yeah,
I do. I just want to say one other thing before I jump into that, and that is, I hear people saying that they haven't had any problems, and I guess what I would urge you to all consider doing, we haven't had anybody here in New Hampshire die, and yet I have talked to several hundred paramedics about this, and in those informal conversations, I found 4 near misses, situations where intoxicated patients were given ketamine, and the patient suddenly became apneic. No one died because they picked it up immediately and immediately jumped on and bagged up the patient. And so no harm, no foul. I'm not even sure it was reflected in the PCR, but it's been startling to me when I started to poke that I found some of these near misses. And the other thing I'd say is it may be worthwhile for all of us. Casey Patrick, I think, had did some work on where he actually looked not just at things like cardiac arrest, but hypoxic events, times when patients were administered sedation and had their pulse ox drop under 90%. And they did see a trend they were comparing ketamine and droperidol and saw that with droperidol, they had fewer of these hypoxic events. Maybe not a end patient outcome that causes us to get very concerned, but probably an indicator of some potential risk. So maybe that's something we should be tracking for these patients that do receive sedation. I do think, to answer your question, Paul, I've asked a bunch of paramedics this question. Obviously, issues for paramedic shortages are pay, burnout, staffing. But yes, I think, of course, the risk of criminal liability adds to the stack of woes that is likely to impact our ability to recruit people going forward. That's my view anyway.
I'm sorry, for New York City too, I do the CMEs with paramedics, and obviously I can't do all of them. I got my other 11 doctors that do it as well. But every CME session, I'm bringing this up now. And they're saying to me, Doc, I'm not comfortable now doing any kind of sedation. And I said, listen, I understand that, but you got to follow the protocols. It has to be indicated, all these things that we've discussed in the past. You can't do it because the cops are asking you to do it. It has to be medically necessary and all this. But I am getting some feedback from my medics saying, I'm not so sure, Doc, I'm not comfortable.
So it may keep people who should get certain drugs from getting it, but it may not necessarily hurt our staffing yet, or what do you think? Anybody have any comment about that? So that may actually be a better question to ask, is it, are they going to be less apt to be wanting to put themselves out there and treat people in certain ways? That may be an interesting question then to ask there on that end. All right. Well, with that, anybody, I think maybe we should do a quick round the room, but anything else you want to say as parting words, Eric? Or and you ought to come down and join us, by the way, in Florida. It'd be kind of fun if you'd like to hang with us. Okay. So
I would love to come down. I guess I'd say that the gentleman from Colorado mentioned the post-intubation monitoring that they built into the program, and I think that's great. But I've seen some programs rely on that sort of as their exclusive intervention. First off, I would rename it peri-sedation monitoring, because I think often with ketamine, waiting until they're completely sedate to start the monitoring is problematic. And I really think it's the entire package of things, just like those programs that do RSI successfully and safely. They built an entire package of pre-oxygenation, positioning, apneic oxygenation, plans A, B, C, and D ready to go. We need to build the same kind of complete package around chemical sedation to ensure it's being conducted safely.
But we will come back, and instead of being focused so much, because that was made a big deal here, we ought to talk about the issue that it really is more the positioning, asphyxia, and all that that's causing a lot of the problems that we're seeing, and that's let's.
I don't know if it's just on my end, but Paul froze.
Not just that's he's frozen.
Looks like Paul's.
Peter, are you with us?
Well, hey, what happens? I think my internet's unstable here at the American Airlines Lounge, but I was just gonna bring Don Jenkins on if he's there. Don, are you still on with us?
I am. So, could I share my screen?
Yeah. Please go ahead. I'll do the thing that says,
how's that? Can you see this document called
Yes, we
CFR
can, sir.
Code of Federal Regulations Title 21? So this is related to emergency release transfusion in the pre-hospital setting. I was really surprised that Chief Eric Bank and I were at a AABB, a blood bankers meeting, hashing through pre-hospital transfusion guidance that they intend to put out. And one of the things that came out in that session was an absolute FDA requirement. It has nothing to do with the AABB, but that every time an emergency transfusion is given, and by emergency, what we're talking about is emergency release blood, that it is not a type and cross-matched thing. And we know that we're taking a bit of an additional risk to give the patient that we perhaps in this setting don't even know their blood type, a blood product. And it doesn't matter what blood product it is, if it's red blood cells, whole blood, platelets, plasma, if it's an emergency and you give it. All right. So for those EMS agencies giving components, this applies equally to those giving whole blood. But if you scroll down on this document in the CFR Title 21, and it's 606.160 called records, you got to go down here to number 3, and what you can see highlighted here in blue is emergency release of blood, including signature of requesting physician obtained before or after release. So if this has not been being done in your setting, we are all in arrears with the FDA on this. This is every unit of blood that didn't come out of a hospital during a transfer of a patient, right? So this is originated in the back of a helicopter, and back of an ambulance, on the street, wherever it is pre-hospital, that there has to be a physician signature associated with that documentation. How one does that and when one does that is entirely up to you. So if that's a batch signature at the end of a month, if that's some electronic version of that, if all you've got is paper legacy things, if you want to sign
growing up here, it wasn't so bad.
if
When I
you
was
want,
growing up here, it wasn't so bad.
if you want to assign a physician surrogate to this, however it is you want to work it out, it is up to you. But I can tell you that Dr. Miramontes and Dr. Winkler are sitting back thinking, wait a minute, I got 1,300 signatures I got to apply to something. I'm not terribly happy about this, but it's in the law. And we'll have to have a plan for this moving forward. I would think that this group would be one to share best practices of how to do that. You guys share a lot of common EMR platforms, et cetera.
Yeah.
So the other thing is down further in this document, it talks about how long you have to hang on to those records. That's down here under D. Records shall be retained. And basically what Chief Bank and I settled on was it kind of means forever.
That's what I was.
So if it lives in the background in electronic format, great.
I remember those days.
Hey, Don, hang on. Hey, Stein, you have an open mic, just so you know. Okay, Stein. Okay. Go ahead. And then, but one thing I did want to ask you, actually, so it's a good point to interrupt you anyways, because I wanted to ask you, does the Federal Register indicate the timeline? Does it have to be done within 24 hours or 48 hours, or what's the timeline on that?
There is no timeline, which is wonderful. We confirmed that with them. So that it doesn't make it easy, but it makes it easier to accomplish that. And that would be not only in retrospect, but in the going forward. So you can standardize when you sign this. Their expectation is that this is done in near real time. I will tell you that they do not understand our environment. They don't care. Honestly, this comes in an unchangeable format. This would take more than a note from the Pope to get the federal government to move off of this. Meanwhile, the AABB has been exceptionally reasonable because they produced a set of guidance that was going to look a lot like what happens in a hospital, which is impossible for us to have these kinds of programs. And they were very receptive to all of the changes that we suggested that make this very doable. But there's just these two things. You got to have the signature, and you got to hang on to that signature, that documentation about that blood. There's more of the story we can get into later, but these two things really we're in arrears on already.
So let me ask you this: is this out as the status, or is it just is this out for review right now, or is this the real deal? And then we got to follow this.
So the FDA lingo has been in existence probably since the 80s. And as you can see by this document here, was last updated in December. Again, the FDA doesn't care about where you are, what you're doing, who you think you are, what environment you're in. This is their rule, and I challenged them on it, and they said, "Good luck, because you're going to lose every time." What the AABB is doing is the reasonable thing about how this happens. The FDA is not going to budge off of this, and the AABB defers. Anything that comes from the FDA supersedes anything that the AABB may want to do, think, believe, whatever.
Tell them a little bit who the AABB is, by the way.
Yeah, sure. So every blood bank has two masters. They have the FDA and they have the AABB. And the American Association of Blood Bankers, it has a different name today. They changed their name within the past 6 months, but the letters they kept the same. So they come in and they review all blood banking processes and procedures. They have a rule book that is like an Encyclopedia Britannica in terms of everything, every blood product, you can't even imagine what the blood bank has to go through to stay in their good graces, or they shut down their blood bank. And they're not reluctant to do so. There is no more regulated environment, not even the pharmacy, than the blood bank when it comes to these rules of engagement. And so for the AABB to let some actual clinicians in the door talk about this and to then be reasonable and allow us to influence this guidance is unbelievable to me. But it's,
all right, why don't you share at this point, and let's take David's hands up. So David, comment, question?
So last time I checked, I've never had the FDA come visit me at an EMS agency, right? So, but that being said, I don't think they have an enforcement arm that reaches to the EMS world. But that being said, so I don't really care about the FDA. What I do care about is my blood bank. I want to make sure my blood bank is happy and in compliance. And in that regard, I'm not worried about the FDA and the EMS world. I am worried about FDA messing with my blood bank. So whatever my blood bank wants me to do, I'm going to just do whatever they want, however I can do it, and make it happen. So that's my 2 points.
So David, I said exactly what you said. I said, who do you think you are? You don't have any jurisdiction there. And they're like, ha, ha, ha. Oh, yes, we do. And then, you know, they point me to this and you look at it. This is in the federal code, brother. You don't get to not follow the federal code.
Okay, good to know.
Sorry.
I guess they could get us. So I guess they could get us through our CMS because
they could. Absolutely,
yeah,
they could.
Yeah, they could do it through the CMS side, which is fine. I'm going to comply. I'm sure Image Trend and ESO and everybody else will figure out a way that if you give blood, that chart's going to go to the medical director's box and you're going to go click. Thank you, I signed it. But we just got to work that through with our vendors.
All right.
Yeah,
And
that's
finally,
why I thought coming to this group would be the way to get that done most efficiently.
Hey, and Don, I don't know if you were on earlier when I talked about having our meeting in Florida in June that week. You know, you know about that. Hope you can even join us at that point in time if it's not, you know, not in interference with your meeting the next week. So I just wanted to keep that in mind. We'll be sending an invite for, as a matter of fact.
And I could come and talk about these AABB guidance issues. You know, 15 minutes.
Sounds great. And we'll talk, that may be a good one for us at Eagle Creek. And I mean, we can mention that as well in the main meeting, but I think that'd be the great time. Eric, anything else you would add on to this so I can move on to the other folks, but I want to make sure I capture you as well.
No, you know, I was with Dr. Jenkins at that meeting. That was one of the ones that kind of took us by surprise, along with, like we talked about last time, you have to have a copy of the blood circular available for the patient. And so we just dropped that into the PDF guidelines. And much like Dr. Miramontes said, for right now, we're probably not going to go back and sign the 175 some odd charts from the past 7 years.
Yeah.
But everything from now forward in the CQI process, the doc will have the chance to sign it.
Okay.
Again, my volume's not near what, you know, Dr. Miramontes is San Antonio is, but I just want to echo that what Dr. Jenkins says, the AABB has really bent over backwards to help us through this process and invited us to the table. And obviously, much like the DEA, the FDA has not.
Now, does the register give you like how that has to be formatted? Does it have to go into some individual chart? Or can you actually have a list of people that you reviewed it and you signed off on them with here's their medical record number and here's the date of the event? Can that be done, or what's the formatting? That's what I'd like to learn about.
There is no format. They are leaving it up to every individual as to how they do that. It's some kind of thing indicating signature and retention. And so if you can just envision, you put some poor person on a task for a week, come up with a bunch of DocuSign documents, and you know, then they get clicked through to sign off on every month, or some other easier button that for inside the EMR. However you want to do it, that's up to you.
Yeah, it seems like if you could just refer back to the medical record and say these are people where I approved the blood use here, you could maybe just even put it on on an Excel sheet and then sign it at the bottom.
That's what I would be doing.
Listen, thanks for alerting us to this. We'll drill down on this more later, but I just want to go ahead and move along and close out the meeting. But thank you so much for the keeping us on track on this very nebulous matter that, you know, that's definitive. So, all right, let's first go up to Anchorage and state of Alaska. Mike, anything to report from up there? I saw you put the note in about you guys were working on a new set of, let's say, guidance for us in regarding the previous discussion.
Yeah, I think that'll be helpful. It's going to be a white paper. We're pretty much closing in on a landing point for it. We consider it to be we were talking about it being transitions from law enforcement to EMS, but really landed on the idea that we talk about the collaboration of law enforcement and EMS as being more of a continuum as opposed to some point in time when, you know, there's a pivot to others. And I think this kind of document will help us with, things like we just saw in the videos that keep popping up, unfortunately, with regard to people in custody.
And then Mike, does it include the concept that we should be proactive again? EMS director or fire chief talking to the police chief and making sure that everybody's in sync on the procedures.
Yeah, I was going to drop a note in on that. I tell you, I did this locally, and I could see the hair on the back of the chief and the assistant chief go up on their neck when I was in a meeting with them and our executive staff. And basically they came back with, what's the problem? I think we work real well together. Hey, whoa, no, we do. But we just, cameras are on and we're going to be seen. We just make sure we're all on the same page and knowing how this is going to work. And you provide safety for us, we'll provide medicine, we'll do it together, and this will work to its best end. Paul, you're muted.
Yeah, the reason why I bring this up is that in the past, we saw where sometimes EMS people were hung out to dry because the police complained that they didn't give the drug or do this when they thought it was not, when the medics thought it was not medically appropriate. And then they got chewed out by their bosses because it went up their food chain, came this way and came down that way for not cooperating. So I think that this is such an important point, what you're doing there. Okay.
I think as you saw in Aurora, once these things happen, the fingers start pointing in all kinds of directions. It's just the nature of law, how these things play out. But, ultimately we're all in the same sort of sandbox. So we've got to make this all work and take the best care of our patients and keep everybody else safe. So it's a closed loop.
Well, as usual, thank you for your great work. Anything new to report from either Alaska or Anchorage?
No, I mean, not really. I'm really absorbing things from the group here. So appreciate it. Thanks.
I hope you're absorbing well and hope you'll be able to, any issues of getting down to Florida this year?
Please recheck in at Frank
Yeah, are you asking me, Paul?
I was just saying, any problems with you getting back to Florida this year? That's all. I just
Oh, no,
wanna
no,
make sure
no.
that-
Well, there's problems with all of us flying these days, but hopefully no more than anybody else. So no, I'm planning on being there and looking forward to it.
Make sure your Alaska Airlines door doesn't blow out, right? So I love it. Actually, what's interesting, by the way, I found that out of Seattle, there was a nonstop to Fort Lauderdale, which I've used, which has been really pretty cool, when I've gone up to Seattle. So
Well, I fly Delta. Unfortunately, all their equipment is so old. I think it was brazed. Everything's been brazed on with and welded and stuck together. So I'm not sure anything is going to fall off that couldn't have already fallen off.
That's pretty funny, Mike. You're the best. All right. Thanks a lot, and thanks for joining us today. It's great. Rob Dunn, let me go over to you real quick. And anything else you want to add into the issue about the police? Because you've always had great cooperation with your police for various reasons.
Yeah, and as many of you know on here is we've been spending a lot of time working very closely with our police as we plan for the NFL draft coming up at the end of April. It's one of those things that, back in the fall, we were having a couple hours of meetings a week and then a couple hours a day. And now it seems like it's half my day every day is on the draft. But we have a very good unified command set up. We've, from day one, we've designated members of the fire department and the police department. And these are actually the people that often work on all of our large scale special events. So we just kind of scaled that up. They just finally settled on the footprint. So we've got about 2 million square feet of footprint. That's all going to be behind an 8-foot opaque fence. And we took our NFL colleagues and walked them around Detroit the other day to show them where the best place to stage some things. Because, when you just draw on a map, that doesn't mean much, right? You actually have to get out there and show people the lay of the land.
What I do want to know is, where did you take the NFL colleagues that we talked about?
Right. So we went out to dinner to a new place after our nice walk, but we did force them to walk many thousands of steps to actually see. But we were able to make our point about where we think the best place to stage ambulances are, which, there's always a little bit of give and take in there, because as all of you who do special events, sometimes your medical people are somehow a lot less important than your signature sponsors and where the beer tents go. So,
hey, so besides the beer tents being the highest risk, what I don't know if it's classified, but what are the highest risk issues with this particular group? What's seen as being the highest risk? Just
Well-
protecting the principals, or what is that?
Yeah, I mean, I think it's all those things, right? Because you've got a complicated group of kind of dignitary protection with the people that actually, the candidates that come in, particularly for the first round. So we've got, get people moved around. The, crowd management of any kind like this is important. We typically, and some of you have these devices, these Evolve devices for detecting weapons at a fairly large distance. We use these at summer events so that we have multiple layers that you're kind of going through before you get to the event to keep it as weapon-free as possible. One of the biggest issues for us is we're doing this on the city streets. So we are closing for some of it for many weeks, a huge number of streets in the downtown core, which affects our response on a day-to-day. These are areas that are around very populated businesses and residential areas.
Absolutely. That sounds like, well, I'm going to try to hop off to other people, but anything else then you can think of right now that we should know about or want to know about, or this is consuming you anyways? Yeah.
Yeah,
All
no,
right,
this is good.
That's good. Well, it's been great catching up with you over the last few days. So thank you so much. And did you get to see, did you see Rick and Eric? Okay. They do
Yes,
okay.
yep,
Yeah,
yep.
good.
Rick Martinez, Eric Osman, they were the leads from their team that were here with us. So
Fantastic. Okay, good. Let me jump over to Crawford because you had to be off the last couple of weeks, Crawford, because you were in the emergency department. Anything new to report out of there?
It's been a violent week for our mass transit system. We had a homicide a day, 3 days in a row there, and then the fourth day there was a mass shooting of 8 high school kids getting on a bus. So it's been sort of an interesting challenge.
So have these been just sort of random things, or was there some purpose behind it, or or is gang,
Well, I mean,
or what is it?
our it's called SEPTA. It's like our SEPTA system is not safe on a good day. But that being said, some of these events were random. One homicide of I think probably a high school kid led to the mass shooting of other high school kids getting on the bus. The video is fascinating to see 3 kids all sort of covered up with masks and stuff running up to the bus and opening fire on the kids getting on the bus. Unfortunately, none of them is dead yet, but at least one was critically injured.
Any problems in the subway systems at all?
Drugs, violence, and homelessness. I ride it every day.
And that reminds me, Glenn, you guys have actually had to call the National Guard in. Tell me about that.
Richie, please.
Yeah, we've had some particularly bad subway violence, people being stabbed, people being shot, people being thrown out to the platform. So the governor decided to activate the National Guard as well as state troopers to come into New York City to assist. Not sitting well with NYPD and our mayor. Matter of fact, our mayor was not at the press conference, and notably so, to a point where the press kept saying, why wasn't the mayor there? So he advises in the media that he was just notified, not discussed with, and things like that. So they're doing these random bag checks now of any commuter that's going down into the platform or even coming up, just to see if there's any weapons or things. And of course, some of the civil liberties folks are like, no, that can't be. There can't be any targeting of certain people. So there's a lot of things going on. But New York has reported actually a decrease in subway crime, but it's just hitting the media when somebody gets shot or stabbed or thrown out the track. So the governor took action because the MTA, the subways really are more state oriented anyway. So she has the jurisdiction to do so. So that's what's going on with us.
Yeah. So is when someone's pushed off into thing, is that accidental or are those really malicious and intended?
Yeah, we'd like to say that we do have occasions where they get dizzy, they feel faint, and they fall onto the tracks. But unfortunately, quite a few are pushed, often by someone who has mental health issues. It's just it's horrible.
I'll just quickly adding to that. We get a lot of people on the tracks, and I think a fair amount of them are opioid use people who are nodding and then just fall.
Yeah. And then Tim, anything since you guys are since you're mixed twixt New York and Philadelphia there in Newark, do you have issues like this as well?
nothing that's come up recently in terms of safety on our trains or anything like that. But yeah, we do get occasionally people fall into tracks from opioids or accidental or get their foot stuck or something. We have some street level trains as well. And then in terms of the ketamine and other discussions today, we have not had any major issues. We're continuing to do 100% QA and medical direction call on those. So far, our program seems to be doing okay.
Here, hang on. You guys have been doing a great job there, and and as you're ramping that up there, I think it's really great. It was a pleasure to visit and meet with you guys, especially since you have great Italian restaurants. Okay, so
Absolutely.
hey, no, but any other problems that you're facing, or what issues are you up against right now?
The major issue we're up against, honestly, regulatory. The state has sort of not committed to state protocols. So we're caught in operating in this strange gray area, and we're trying to hire a state medical director, which we don't have in New Jersey. And so we're all just trying to figure out how to operate absent state level leadership. And part of that is figuring out how to operationalize blood in the state because we don't have any clear guidance. So we're trying to do more of a grassroots efforts amongst different projects to organize ourselves and propose it.
All right. Great. Thank you much, Tim. Great to have you on. Looking forward to having you in Florida, I hope. Okay. So, hey, Dave Obert, anything to report out of the Pacific Northwest there?
Not too much. It was a very interesting conversation today on the ketamine. I mean, from our perspective, it's a slightly different. It's not a delegated medical act system. So paramedics are operating under their own emergency medical assistant licenses. They have clinical practice guidelines. And in terms of ALS care, it's a targeted system up here. So for our ACPs or ALS level, they actually have a wide variety of indications for ketamine, and it's quite commonly used. So we use it for analgesia, procedural sedation. We don't have RSI, but we do ketamine only breathing intubations. So just ketamine as the induction. And then we do use it for hyperactive delirium with the guideline stating for RASS of +4 and up to 500 milligrams, 4 to 5 mg per kg. So that's kind of how we are utilizing it. Have not had significant issue. I mean, I think it's been said, by some of the other medical directors. We also enjoy up here a good sort of working relationship with our policing partners, and I think that's so far it's been going well. We also have midazolam in our toolkit.
Yeah, I really should be wrapping up right now because it's 12:01 here in Central Time, and 10 o'clock your time. But just curious, is there differences in emergency medical, let's say the call demand or the different kinds of cases you see between, say, Victoria and Vancouver, both large cities, of course, Vancouver much larger, but are they pretty identical to some extent in terms of responses and the kinds of cases that you see there, or do you see differences there? Are there more big city issues in Vancouver, for example?
I mean, obviously, Vancouver has probably a few more of the sort of big city issues, similar to big cities in the US. But generally speaking, I think the responses between metro areas, Victoria included, are fairly similar. I think for us as an organization, it's how do we deliver sort of high level quality care out to some pretty rural and remote areas. I mean, it's a big province, 1 million square kilometers.
Is there a major homeless program there, just like they see in, just near you in Portland and Seattle, or is it different culture?
It's very similar. We have an area called the Downtown East Side, which has many of those same issues that Portland and Seattle and other areas would have.
Okay, got it. So let's run down let's run down I-5 here and get into Portland. And John, anything new to report there from your city?
Not really anything new. We have a 90-day emergency declaration regarding fentanyl, and it's not really going to change anything except for collaboration and communication between our first response agencies. There's been major, I would say, improvement in collaboration between city, county, and state from a communication point of view. Other than that, everything is status quo.
And John, there isn't time, but you think, will there be some interesting things to run by us in terms of infectious disease or communicable disease next week?
Yeah, I can look at what's on. Everything is sort of status quo, at least on the West Coast. Everything is sort of a close, dull. In other words, no real spikes in any infectious diseases that I know. But in the rest of the area, I can speak to that.
Hey, one more question, since I'm an elder, is there a new Pneumovax out, and is it a new and improved out there? I just curious to know.
New Pneumovax. Don't know enough about it. So the answer
Look,
is,
yeah,
I
look
don't
into
know.
it, because we'd heard that there was, but I don't know if that's secondhand, so I was just curious.
Okay.
Okay, good. Let's go down I-5 all the way down into Los Angeles. Anything, Mark, do you have for us?
Nothing too exciting. We've got the Oscars coming up. We're
Oh,
actually
yeah.
one of our advanced practitioner units on the campus. So it sounds very exciting, except they have to be there at 10 a.m. and I think they're supposed to be there until at least 11 p.m. So hopefully they'll enjoy it, but I'm not going to be there.
I'm hearing that they're going to see red this year. And if no one knows what I'm talking about, is that there was a big hullabaloo about the red carpet. They took it out last year to make it look like a champagne evening, I think, to match some of the other things that were going on. And they was very upset about that. So the big issue is that the red carpet's back this year, right? So
I heard
there'll be,
it's going to be very short. So it's, again, it all looks good on TV, but in real life, not so much.
Exactly right. Okay, good. Thanks. Libby, let's just go out to you real quick. Anything to report out of Hawaii?
No, just some administrative stuff going on, but nothing terrifically different in the field. Thanks.
And will you be able to join us this year? I hope.
I will not. We're doing a family reunion and we're gonna do a trek in Japan.
Okay, got it. That's too bad. We'll really miss you, but thank you for being here every week, etc. And then what happens with daylight savings time coming on Sunday? What happens with your time?
So the Eagles meeting will start at 5:30 a.m. for me now.
Oh, God.
We'll be 6 hours different from East Coast.
Oh, God. Okay. So anyway, so thank you for being here. We are so flattered that you're on every week and just loyally. So it's really good. So it's really fantastic. Okay, good. Anybody else have anything else to throw in? Paul Banting, anything from you? Anyone else that's on right now? Because I think we should let everybody go, and I got to go board my airplane.
No, we're all
Are you
good.
there?
Yeah, we're good.
Okay, good. And we are good, right? You and I are good. So
Yeah,
I had
thank you.
yeah, everybody's happy. I got Chris started away, Rob, all those. Looks like we're gonna have a good meeting. So it's fantastic. Okay. So
Looking
thanks.
forward to it. Thank you.
All right. All right. I better go, everybody. So welcome back, my friends, to the show that ends next Friday. And thank you all for what you do. I hope this has been interesting for you. And it's always kind of fun because you never know what we're going to get. It's like a box of chocolates, as they say. Okay, so I'll see you later. Signing off. Bye-bye.
Thank you.
See you 1 hour earlier next week.